Okay. Now we move on to the next section, a very important aspect and something we are always focusing and debating about. So a literature review on the molecular diagnostics and diagnostic stewardship. This review would be taken up by Dr. Pragyan Kumar Routray. He is the HOD Critical Care at Care Hospitals, Bhubaneswar.
So very good afternoon again. Again, I would like to thank ICCM Hyderabad for inviting me. So unlike my last lecture, I would request all of you to sleep. It's a very difficult topic, literature review. Even while preparing, I also dozed off twice. So let's see how many person are remaining awake till the end. So topic, literature review, molecular diagnostic and diagnostic stewardship. So very interesting one. So before I go deep into it, so we need to know why do we need it? Why do we need to discuss on this pertinent topics? How it is affecting our critical care practice? So my August audience, needless to say, they all deal with sepsis every day in and day out. Every 2.8 minutes, one person dies of sepsis. There are a lot of community acquired infections, a lot of nosocomial infection. I won't be bugging you with this. We know the pretty well this is happening. There are a lot of diagnostic challenges. Like we need a diagnostic test which will have rapid detection, broad-based detection, low specimen volumes should be picking up the infection. It should have high sensitivity, high specificity. It should be able to detect polymicrobial detection. It should be able to detect drug resistance. It should be we should be able to detect it with minimal technical expertise so that it can be done in a distant peripheries. It should be picking up unknown and emerging pathogens. It should be negating the host and pathogen driven SARS. So it seems to be a very tough job. Along with therapeutic challenges like mortality rate is more than 50 to 85%, and with 1 hour delay, mortality increases. Taking into account all of these things, we need three things to be done: right diagnosis at the right time, right antibiotic, and right timing of the antibiotics. Whatever therapeutic maneuver you want to do. But interestingly, whatever happens, wherever a topic about sepsis is being dealt, every listener gets a take home message of right antibiotic, right antibiotic, and right antibiotic. All other things we miss out. That is why we say that hit hard and hit fast. So every nook and corner now, as we are talking, every ICU somebody is hitting hard and fast to somebody there. No, so everybody is hitting somebody with a right antibiotic, with hitting hard and hitting fast. Let us go to the other extreme. When we talk about the other extreme, can you believe way back in 2014, 519 million antibiotic prescriptions were dispensed in India. This is a rough figure. So 412 prescription per thousand population. So roughly every 1 in 20 person have got an antibiotic prescription every year. That's phenomenal. And needless to say, inappropriate prescriptions is a major source of antimicrobial resistance. Coming to the depth of the problem, approximately 7 lakh deaths globally are occurring due to hospital-acquired infections. In USA, 2 million people acquire hospital-acquired infection every year with the death of more than 1 lakh. Any nook time, 1 in 31 hospitalized patients in US is having hospital-acquired infections. Coming to India, 71% of clinical isolates of Klebsiella are resistant to carbapenems. Amongst TB, 1,20,000 have classified as MDR TB way back in 2020. We don't know what's going to happen now. And in 2021, roughly 77% of the antibiotics in India were sold without prescription. That is the situation over here. And if you ask the market, the global economic impact of antimicrobial resistance could range from 2 trillion to 100 trillion by 2050 if not effectively addressed. And as we know pretty well, we are unable to effectively address it. So it is going to go up and up and up and up. So to my friends who are very savvy, very fond of stock market, so you also start hitting hard and fast in your ICUs and also put some stock market in the antibiotics from. So by 2050, the market is going to be 58.48 billion. So continue hit hard and fast and continue to pour your money on the pharma industry as well. Both way around will be succeed. So we are now hanging between two extremes: diagnostic stewardship and antimicrobial resistance. And probably a small subset of molecular diagnostic might help. So my literature review will be covering diagnostic stewardship and molecular diagnostic in a little way. Let's start with that. So global antimicrobial resistance surveillance system that was started 2014. They defined diagnostic stewardship in a very beautiful way. It's a coordinated guidance and interventions to improve appropriate use of microbiological diagnostics to guide therapeutic decisions. It should promote appropriate timely diagnostic testing, including specimen collection and pathogen identification and accurate timely reporting of results to guide patient treatment. So the 5 components to it: timely diagnostic, timely and right specimen collection, right pathogen identification, timely reporting and treatment per se. So the main objective of microbiological diagnostic stewardship should be to deliver patient management in proper way and to have a antimicrobial surveillance data. So there are 2 components to it. Number one component is patient management, the patient sleeping in front of you, there you're managing well, as well as you're taking care of overall antimicrobial resistance surveillance. So in this ecosystem of healthcare where we have a clinician, a patient, a healthcare system, a test ordering, test reporting, so this whole system revolves around diagnostic and therapeutic stewardship. So in coming few minutes, we will be discussing some landmark trials starting with diagnostic stewardship. So I'll be covering just articles about Clostridium difficile, respiratory, blood cultures and urine cultures. And along with that, I'll be telling you how human behavior is very much part and parcel to this stewardship program as well as studies they have done. Let's start with that. So this is the impact of computerized clinical decision support tool on inappropriate Clostridium difficile testing. So as we know, whenever we see in our ICU somebody having 4 or 5 loose motions every day, we ask for a C. diff testing. So there was a huge amount of C. diff testing being done in this Cambridge University. So what they did, they told that whenever you are ordering for a C. diff test, a computer program will pop up. They'll ask whether person has received any laxative in last 36 hours or not. If that knowledge comes into your preview, you are free to decide whether you'll continue to do the C. diff test or you'll stop over there. The study was done 2014-2016 and it was compared with a baseline year of 2013. So whenever you're asking for C. diff testing, computer is telling that just check out whether patient had received laxative or not. That's interesting. So they found out that whenever computer is asking them while ordering, of course it's a paperless system, compared to study period, C. diff testing decreases significantly. Just somebody nudging and telling you that see whether patient has received laxative or not. If you know that, probably you will be stopping the orders at that time. So that's pretty interesting. So intervention was remanded to check for laxative use when ordering stool testing, and outcome was reduction in appropriate testing. It's very simple study to do, very simple thing to do in your ICU as well. Just remind yourself that whether person has received laxative in 36 hours or not. If person has received, no need to do the C. diff test. So another study about same electronic tracking of diarrheal episodes and laxative therapy for enabling C. diff testing criteria and reduction of C. diff infection rate. So what they did, what happens in our practice, we clinician take the upper hand, we send for test, we never listen to anybody. In this study, they empowered the microbiologist to cancel the C. diff testing orders if this clinical criteria are met. If more than 3 loose stools in past 24 hours and if there is absence of laxative use, then only microbiologist will take up the test, otherwise microbiologist will cancel the test on its own. He or she need not check with the clinician. That's pretty interesting part. So there occurred 32% decrease in CDF testing and it did not have any significant increase in ICU admission or a 30-day all-cause mortality. So if you give a upper hand to your microbiologist to see, to negate the test, if they are not meeting the clinical criteria, then also it helps, it is helping a lot. So this beautiful graph says a beautiful thing. These are the whatever it was what was happening previously. This was the intervention period where microbiology started stopping all those tests where criteria are not meeting in terms of more than 3 loose stools as well as not taking laxative. So believe me, even after the intervention period, people started sending the reports in a lesser rate. So some sort of intervention can change your human behavior like anything. So if you have been sending for 2012 to 2015, the study period shows almost equivalent rate of sending of C. diff test, while a small intervention of span of July to 3 months intervention can decrease your rate of sending C. diff. So that's how human behavior changes. Next test about respiratory system. So we all know this is the way our practice changed also. Invasive sampling in terms of BAL, mini BAL versus non-invasive testing in terms of ET aspiration. There's no difference in mortality, ICU length of stay or mechanical ventilation or change in antibiotic. That's a very significant study. And this is another study which we always send ET culture and sputum culture, and most often it comes as a colonizer or polymicrobial respiratory flora. So what happened? They told the microbiologist in an intervention way to write specifically there is no MRSA, no Pseudomonas species. Earlier reports were telling that patients having polymicrobial respiratory flora, it's colonizer, report ends over there. So microbiologist told specifically write no MRSA, no Pseudomonas species. Believe me, only by doing this from the microbiology side, it improved de-escalation increased from 39 to 73%. Median duration of anti-pseudomonal antibiotic decreased from 7 to 5 days. Significant decrease of MDR isolation ratio from 8% to 1%. Just believe it or not, just your microbiology friend just changed 2 lines in the report saying that there is no MRSA, no no pseudomonal species in it. This is how human behavior acts. This is another study where they tried to use level of IL-1 beta and IL-8 to discontinue therapy, but it didn't act out well because most of the physicians not very much aware or very much keen to react to this level. So that's why it didn't work. So outcome was nil. Then coming to blood culture levels. So post-operative patients, mostly as you have seen day 1, day 2, they'll be having some sort of fever. So there's a tendency to send for blood culture. So they put up a criteria that if somebody is having hypotension, fever or more than 2-day post-operative fever that is lasting for more than 2 days, then only we'll be sending blood culture. That's the criteria they have put down. And with this stringent criteria put up, they have found that 85% reduction of blood culture orders while maintaining the safe diagnostic yield. So they found that if you are withholding yourself from sending blood cultures, if they are not meeting this criteria, then also you are having significant decrease in blood culture order from surgical ICU. This is a very nice way to put up. You can take this study to your surgical colleagues and tell them to act accordingly. And there are a lot of fascination about sending blood cultures anyhow, irrespective of the antimicrobial level. So this study says that so after if somebody is on antimicrobial, the diagnostic yield of the blood culture decreases by almost 20%, whether you send 1 culture, 2 culture, 3 sets of blood culture. Roughly in best of the best lab, it decreases by 20%. So try to send it before starting antibiotic. That's what the take home message. Last 2 studies about urine cultures. So this is a study which came in Journal of Hospital Infection. The urine cultures are processed and reported only if at least one of the following criteria were met. What are the criteria? Presence of pus cells or bacteria on microscopy, and patient belongs to obstetric, urology, pediatric, oncology or renal transplant ward. So these are the patients where they're keen to get a UTI and a severe UTI. If all these criteria are not meeting, the microbiologist may not process the order. He or she might process the order, but he won't report it. So what they found? So this beautiful study, they took 12,282 urine samples, out of which 38.7% specimen did not meet the criteria. They were probably some sort of asymptomatic pyuria. And 163 of this non-reported, they didn't report the case, but this put them for culture only. They have found that this grew E. coli most often, and no patient with unreported urine culture developed bacteremia from untreated UTI. Believe me, if those cultures would have been released to the physicians, they would have started some antibiotics per se. It would have led to havoc in the patient, that might have increased the cost of therapy, that might have increased the stay in the ICU. But interestingly, if you are not getting this criteria, you do not have white blood cell in urine, if you do not show bacteria on microscopy, you can and you do not belong to this subset of your patient, doesn't belong to this subset of disease group, then do not send for urine culture because they do not yield anything, and in the long run it doesn't lead to any bacteria or any septicemia in these patients. There's another beautiful study published in Infection Control and Hospital Epidemiology, where they find a modified reporting of positive urine culture to reduce inappropriate treatment of asymptomatic bacteria. So if you are getting asymptomatic bacteria, if your bacteriologists are not vehement enough to put that in the report, you always shy away from not starting antibiotic. Your tendency is to start some sort of antibiotic. So they took 110 consecutive inpatients at 2 urban acute care hospitals. They were randomized to standard report or intervention. Standard report showed everything like bacterial infection, antibiotics, etc. But the intervention group actually, they represent a asymptomatic bacteria or UTI. If UTI is suspected clinically, please call the microbiologist. That's what the report says. Report says that the urine culture is showing some sort of asymptomatic bacteria to my knowledge. Kindly call back if you would like to, if you are seeing clinically patient is having urosepsis. Believe me, that lead to significant use of higher rate of appropriate antibacterial therapy. So just your microbiologist writing that, just see if you're suspecting a genuinely clinical UTI, do call me. That itself makes you feel bad and you stop using those antibiotic, and appropriate antibiotic therapy rate increases significantly. That's how human behavior comes into picture. So those are the articles beautifully that I depicted about diagnostic stewardship. There are huge article burden. I picked out few of them. Coming to the next part, role of molecular diagnostic and diagnostic stewardship. Although we have lot of articles, I have picked up few of them. It's a upcoming science. Probably pre-COVID, we had some sparse knowledge regarding that, but post-COVID, RT-PCR become a household name. Everybody is attacking RT-PCR. What is the CT time? Probably it's a 40-year story of molecular diagnostic where Carey Mullis he derived this procedure of PCR and received Nobel Prize. Ranbaxy brought it to India in 1997. Initially, it was used for TB, HIV, hepatitis B, HCV, and 2000s. Other referral lab also got it. We were initially testing for CMV, dengue, H1N1. Then 2010, actually, Gene Expert 2.0 also came into picture. It's a very beautiful way of taking care of DNA. So, if DNA or RNA coming and you are denaturing, you are annealing, you are doing extension, and you are growing it, and accordingly you are subjecting to different tests. There are a lot of advantage of real-time PCR in the sense that it is very rapid, it can detect wide range of pathogen, and some PCR guide regarding possibility of drug resistance as well, and it is way better than culture. I'll be showing some articles supporting these things. And lately, we are going beyond single test PCR. We have multiplex PCR when within a single test we can detect multiple bacteria. We can check bacteria, virus, fungi, all of them together, which is not possible with routine culture. As we say, routine cultures can pick up 1/10 of variable bacteria, viruses, fungi that we have. PCR can detect almost all of them. So what are the evidence? Let's go to the literature review of the evidence. What are the evidence we have? So I will be showing some evidence in respiratory samples at the better than routine cultures, some about blood, CSF, syndromic panels, and antimicrobial. So one of the major guideline which had supported this PCR system is a joint statement by ERS, ESSM, XMIT, and ALERT guidelines for management of severe community acquired pneumonia. In the guideline, the first question they have put up is, in patients with severe community acquired pneumonia, should rapid microbiological technique be added to current testing of blood and respiratory tract samples? It came way back 1 year back only. The answer was very subtle. So if the technology is available, it's directly from that guideline. We suggest sending a lower respiratory tract sample, either sputum or endotracheal aspirate, for multiplex PCR testing. So this guideline is one of the perhaps the only guideline that has added multiplex PCR. They are saying that in a severe community acquired pneumonia, if you are prescribing a non-standard antibiotic, do send a multiplex PCR testing. Coming to some other few articles that I have picked up. Multiplex PCR could change diagnosis of VAP in pediatric critical care. So there are a lot of studies have done in pediatric population. They have found that multiplex PCR permits simultaneous detection of several bacterial pathogen in single reaction with best turnaround time. So it permit optimization of emergency diagnosis of VAP and subsequently improving early management. There's a very nice conclusion from this journal. So another of it, whether assessment of usefulness of multiplex real-time PCR test in diagnostic and therapeutic process of pneumonia in hospital children. So mostly pediatric population, they have found that it's more useful in establishing the etiology of pneumonia compared to your standard care that we are giving. And coming to bacterial etiologies of LRTI, so diagnostic performance of RT-PCR for bacterial detection is 43%, was significantly different from routine culture, which was 17.7%. So if you're sending somebody for routine culture, the yield is roughly 17.7%. Yield of multiplex PCR, RT-PCR is roughly 2 to 3 times more than your routine culture. We have an Indian study? Yes, we have this Indian study, Sengupta et al. They have reported that PCR identified the pathogen in 59.3% of the patients, while culture could identify only 37.8%. That is again 1.5 times more than routine culture that can detect. As we all know, where bacteria are not alone, virus can also cause lot of LRTI. This study itself proved that 59% patients had bacterial infections, while 22.5% patients had viral infection in this last study, which has taken 2000 patients of pneumonia. So how does multiplex PCR help in detection of viruses? So this study by about respiratory pathogen in infants diagnosing acute lower respiratory infection in tertiary care hospital, they have found that multiplex PCR are able to detect 82 out of the 100 viral infections and multiple pathogen in 34% of the patients. That's quite astounding. They have found that in infants, viral infection is so common in that particular hospital. Again, coming to virus infection causing SARI, in less than 5 years age at tertiary care hospital Rajasthan, the overall positivity of virus was found to be 72.9% with co-infection rate of 19.5%. Again, multiplex RT-PCR was the major breakthrough that could detect this infection that had led to early treatment in a good way. Atypical pathogens also are very common in LRT, as we know that, like Mycoplasma, Chlamydia, Legionella, and believe it or not, they multiple PCR is very pertinent in detecting this infection as well, which are not very keen in getting in routine cultures. Coming to PCR based rapid sepsis diagnosis effectively guides clinical treatment with new onset of SARS. So we are always bewildered by any new onset SARS, whether it is pancreatitis happening, whether patient has had a new infection. So studies have proven this, published in archives. This studies is published by Lord et al. They found out that multiplex PCR helps in analyze a blood sample for infectious agents in patient with new onset SARS. Thus, they showed that PCR test results guide clinical treatment successfully. So in all patients of SARS where you are confused whether to start antibiotic or not, it has been clinically proven that if you use multiplex PCR blood multiplex PCR, you are able to delineate between SARS due to other causes and SARS due to infection very nicely. Coming to bloodstream pathogens, whether multiplex PCR are good enough to pick up infection bloodstream pathogen? Yes. Compared to routine blood culture, PCR test results in two-fold higher positivity rate as shown by Slehman et al. Study, which is a very remarkable study which shows that you send a routine blood culture, you send through by PCR, PCR is 2 times more effective in detecting the organism. It increases sensitivity significantly. Coming to multiplex PCR in bacterial meningitis, yes, their diagnostic yield is pretty high. So in this study, they have found that multiplex PCR are able to detect 36.6% of the instances they have picked up the organism, while routine bacterial culture picked up 21.8%. So interestingly, they have found that if you are using both of them, yield is pretty high with 42.5%. So probably in the CSF in children, they have done this study. If you use both of them, getting a diagnostic yield is very, as you understand that meningitis is very lethal, very potent. If you are unable to treat at the right time, it causes mostly mortality or some sort of morbidity. If you're using both the things in this study, says that both the things multiplex PCR along with routine culture, it helps in a very good yield. Accuracy of real-time PCR Gram-Strength cultures for normal. This another study about a CSF pattern only. They have found that real-time PCR is highly accurate, might be useful when antibiotic were previously administered. So this subset of patient, they try to do a routine PCR in patients who have already received some sort of antibiotic therapy. In this subset of patient also, they have found PCR able to pick up much better compared to your routine culture in CSF. Coming to syndromic diagnostics testing, that we know, we do a fever panel, we do a pneumonia panel, we do a respiratory panel. So syndromic diagnostics testing is going to be a new way to approach patient care in the treatment of infectious disease. Probably PCR doing a syndromic diagnosis is going to be a game changer, as shown by this article. So you can put up an array of culture in a fever panel. You can do all those tropical fevers together, and PCR can pick up within 6 hours. So if you have a syndromic panel, that also helps out. The studies proves the same thing only. Coming to this study, molecular testing also helps in de-escalation. As we are discussing about picking up the right bacteria, even multiplex PCR can help you to de-escalate antibiotic at the right time, as shown by this study which is published in Clinical Infectious Disease. Coming to other things, so we have a very beautiful study by CMC Vellore which is going to be published very recently. They have found that multiplex RT-PCR helps in bacterial infection and detection of antimicrobial resistance gene, and is an excellent diagnostic accomplishment as well as useful diagnostic tool in sepsis management. So in CMC Vellore have used this methodology to do and compared it with routine bacterial culture, they have found it to be more effective. So along with what we understood, that it is very effective, very efficient in detecting bacteria at the right time, very effective in detecting syndromes, very effective across all samples, you name it, mostly blood or sputum, urine, there are very sparse studies. Along with that, we understood that it also picks up a lot of syndromic challenges as well. Along with that, interestingly, it also can detect some sort of antimicrobial resistance gene that we are now getting very quite often. So resistance is the story everywhere. So you can detect drug resistance genes in a very effective way. Accordingly, you can use your antibiotic wisely. There are a lot of studies which have identified specific resistance of E. coli quickly, accurately, allowing for tailored antibiotic therapy. So, a lot of studies have proven that it enhances diagnostic accuracy and change in antibiotic therapy up to 40 to 60%. Overall sensitivity increases to 90%. It helps in surveillance and epidemiology as well. So, to summarize, literatures plenty supporting diagnostic stewardship and molecular diagnostics. Of course, guidelines are sparse except your estimate guideline which said that we can send this multiplex PCR for respiratory sample if you are suspecting a severe community acquired pneumonia. Both are very pertinent. I mean, diagnostic stewardship and molecular methodology for individual patient care as well as surveillance. With rising antibacterial resistance, both of them are going to be our only hope. How we bypass our behavioral patterns to use our clinical acumen in utilizing this needs to be seen. I think with this I'll stop. I would love to take up any question. Thank you.